today's topic is women's health and dysautonomia. And it's very important because we know dysautonomia disproportionately affects women. About 80% are women of childbearing age, young women. You can't hear? Hold. I was promised that it will work by the video person. It's the distance? Well, I'm just gonna hold it. That's fine. I'm gonna perform. Okay. So, is that better? Okay. So we know dysautonomia disproportionately affects women. About 80% are women of childbearing age. So it's very important we discuss this because, years ago, not only people didn't recognize dysautonomia, there was no research on women's health, on what happens in pregnancy. And a lot of the times patients would ask questions. Young women, can I have a baby? Is it safe? Am I going to have complications? Can my body handle it? Am I going to get a C-section because of POTS and I can't do Valsalva? There were many questions. So years ago, I decided to do a study on POTS in pregnancy, and there were only mine and two more that came out at about the same time. And those are small studies, so we still don't have a lot. We don't have a huge sample size, so everything I talk about is going to be based on these small studies and also my professional and personal experience with these disorders. Okay, so we'll talk about hormones, women's health, and at the end, we'll also talk about sex, because it's an important part of women's health. So this is not a PG-13 kind of presentation. I'm going to be channeling Dr. Ruth at the end of this lecture. Oh. Okay. So chronic illness impacts women's health, obviously, through menarche, menstrual cycle, pregnancy, postpartum period, breastfeeding, sex, menopause are all important stages in any woman's life, but chronic illness will affect it, and so will dysautonomia. We'll also talk about Ehlers-Danlos and MCAS. In the life of chronic illness, each of these stages could be affected. And obviously, chronic illness isn't really a positive experience biologically, socially, psychologically, so it's going to have some negative effects on everything, starting from biology, ending with relationships and child rearing and all that. Biological effects on a woman's health. We know that dysautonomia can cause altered physiologic processes that can affect menstrual cycle, pregnancy. In particular, it can be affected because there are hormones and cardiovascular status and sympathetic overactivity and blood pooling and decreased endurance, all as part of dysautonomia, POTS, and others. We know in EDS there is joint pain and dislocations, and they can become worse because of estrogen and lax joints. Flushing is very common in MCAS, and heart rate and blood pressure changes can also occur in patients with dysautonomia. Pain during intercourse is a significant problem as well. Pelvic floor dysfunction is common with Ehlers-Danlos, interstitial cystitis, vaginismus, and vulvodynia with mast cell too. Medication side effects in patients with chronic illness obviously can affect many things, starting from your period and pregnancy and perimenopause. So what are the psychological effects of chronic illness? You guys know them all. Anxiety, low self-esteem, grief, depression, fatigue and pain, altered relationship dynamics, role of partner as caregiver, and the pre-existing relationship problems, if you have them, will be worse if there is chronic illness involved on a daily basis. The social effects of chronic illness are numerous. First of all, society assumes that chronically ill patients do not have sex or may not want to have children. They are ill. That's what society assumes. Yet research shows that sex remains a vital part of life for patients with chronic illness, even for those with severe disabilities. Of course, patients and physicians have difficulty communicating and discussing sexual problems. We're not trained in this, right? If you have questions, maybe we'll answer, but we're not going to be discussing, in details, because we just don't get a lot of education on that. And as physicians, we also assume that sex is not important or not worth discussing. And if your blood pressure is 80/50 and your heart rate is 120 resting, we're not going to be concentrating on your sex life. We're going to be concentrating on stabilizing your vital signs. We have time limits. I take my time with patients, as you know, if you're my patient. But if you have 10-15 minutes for a patient encounter, you're not going to be discussing even questions of, is pregnancy safe for me? So as we discussed, dysautonomia predominantly affects women of reproductive age. And we know that POTS often starts around or after menarche, postpartum, or during perimenopause. We know there is a strong hormonal component. Again, not too many studies are concentrating in those areas. Hopefully people will become interested more and more. Symptoms of dysautonomia worsen during menstruation. We know some people improve with oral contraception, and we also know that men with dysautonomia may have low testosterone level. That's also important. So there is a hormonal component. So what disorders are common, what GYN disorders are common in our patients with POTS, EDS, and MCAS? So studies, again, those small studies I'm talking about, in POTS showed a higher incidence of endometriosis, ovarian cysts, and uterine fibroids. In EDS, there is pelvic floor dysfunction, interstitial cystitis, uterine prolapse, menorrhagia, dysmenorrhea, and dyspareunia. Vascular EDS is a separate type, and there you have risk of uterine rupture and placental abruption. With MCAS, you see interstitial cystitis, vulvodynia, mastitis, menorrhagia, and dysmenorrhea. So we get to the discussion of POTS and pregnancy. And there were many myths as early as 10 years ago. A lot of us, even in this field, the specialists whom I know, had these false assumptions because we just didn't have information. So patients, when they would see one of us, no names, would be told something like, you have to feel well and off medications for a year before you get pregnant. Why would that be the case, and how can that happen when somebody has a chronic illness? That was actually said by some of us. You can't take medications during pregnancy. You may need to be on bed rest during pregnancy due to POTS. Those are all myths, obviously. You will feel great during pregnancy due to high blood volume. You may need a C-section because pushing in Valsalva can result in fatigue and blood pressure and heart rate issues. Epidurals can drop your blood pressure, so it's best to have a natural birth. If you've ever had a natural birth, I don't recommend it. Don't have a baby, you may pass on POTS or EDS to them. So those are POTS and pregnancy facts as we know. We know that POTS is not a contraindication to pregnancy. We know that the rate of hyperemesis may be higher than in general population from my small study. And it makes sense because, migraine is the most common comorbidity, and the migraineurs often have hyperemesis. POTS has a variable course during pregnancy and postpartum period. Variable. Doesn't mean much, of course, but that's what we know. Some do okay, some get better, a small percentage. Mostly people stay the same after first pregnancy. So about 50% of women in my study felt same or better 6 months to 1 year postpartum compared to before pregnancy. In another study from Mayo Clinic, the conclusion was that autonomic testing was not different between women who had children versus who were never pregnant. So it didn't adversely affect objectively their autonomic dysfunction. All of us believe that there appears to be no maternal or fetal complications due to POTS. You don't need a C-section for POTS, and you do need an epidural for pain control. Even if you're a healthy woman, you need an epidural. So in my study of 17 pregnancies, as we were discussing, we did find severe vomiting or hyperemesis in 59%. There was obviously fatigue and elevated heart rate and hypotension, because those are symptoms of dysautonomia and also symptoms of pregnancy. Presyncope. Preeclampsia occurred in only 2 pregnancies in 3rd trimester. Again, small studies. We need very large studies to understand more. But nobody is doing them, as far as I know. Maternal and fetal outcomes. Again, we had 14 vaginal deliveries, only 3 C-sections. There was 1 placental abruption. Prematurity was in 2 infants. About 40% of patients were under maternal fetal care specialist, and then they were seeing cardiologists, 24%. So clinical course of POTS. During pregnancy, 6 months postpartum and 1 year postpartum, you see it in this table. About 1 year out, about 50% felt worse. And 40% were about the same, 10% thought they were improved, all subjectively through questionnaires. So the conclusion of that small study was that unexpectedly higher miscarriage rate occurred in this small sample. Migraine was the most common comorbidity. Presyncope symptoms were occurring in 80%, syncope in 20%. In our sample, family history of POTS or NCS, neurocardiogenic syncope, occurred in 40% of patients. So there was familial predisposition. Time from symptom onset to POTS diagnosis was 0.2 to 35 years, mean 10.8 years. And that was about 10 years ago. Now it's better. I can see that. Medications during pregnancy, 20% use beta blockers, Florinef, Midodrine, and 50% chose not to use medications. So we're moving on to Ehlers-Danlos and hypermobility type, hypermobility, yes. It's not a contraindication to pregnancy. In larger studies of Ehlers-Danlos pregnant women, preterm birth occurred in 25%, spontaneous abortion in 57%, infertility was very common, 44%, and amazingly, only 33% of women had normal menstrual cycle. Dysmenorrhea was in 92.5% and dyspareunia in 77%. So the numbers are very interesting and striking too. So what if you have dysautonomia, Ehlers-Danlos, and you want a baby? You want a baby, what do you do now? So as I discuss with my patients, and also there is a section on that in the POTS book, you know what I'm talking about, that first POTS guide that I co-authored too. Having a baby is a major life decision. And thankfully, dysautonomia and EDS are not contraindications to that goal. But they present challenges, of course. And they can interfere with biological, social, psychological aspects, as we discussed before, in raising a child. But women want children, right? And so this biological, natural drive is often very powerful. And for women with dysautonomia or Ehlers-Danlos who want to become pregnant, there may be current and future limitations imposed by their chronic illness. So you gotta discuss it with your family first. You gotta discuss it with your specialists in POTS and EDS and your OBGYN. Review available literature if you understand scientific literature, and consult with maternal fetal specialists, but in my experience, a lot of them don't know what POTS is. So that's a big problem. Maybe some know about Ehlers-Danlos from the area I practice. POTS is still very much under-recognized. So if pregnancy is not possible, consider adoption, being a foster parent, surrogacy. And I always tell women who want to have kids with chronic illness is that it doesn't need to steal your dreams, but it may make it harder to achieve them. So they have to stay informed, flexible. We all know it takes a village to raise a kid, and even more so, 2 villages for chronic illness. So pre-pregnancy checklist is also something from the book, but you gotta ask yourself, if you're a young woman, do you feel well enough to proceed with pregnancy? And that may be different for different people. For some people, well enough means that they run marathons. That's their baseline. But everybody has a different baseline. Did you discuss your plan with SPOT specialist, OBGYN, primary care physician? Did you review your current medications and discuss with your team which medications are fine to continue? Because not all of them are. Things like clonazepam, we try to wean off. Adderall, we try to wean off controlled substances. Do you have a good support system? Should you become sick during or after pregnancy, do you have financial means if you can't work? That's very important. People don't realize. Maybe people are doing so well, and then something happens, they can no longer work. It's very important, those issues. Do you have enough help from family members, hired help to care for a newborn while feeling symptomatic and or sleep deprived? A lot of the times, if you're a first-time parent, you don't even know, you just want to be. And then when the baby comes, it's like, oh my God, sleep deprivation, you don't get to eat, you're running on empty, and it can be hard if you're a single mother, for example, and don't have anyone to rely on. Can you, and that's very important, can you accept that you may not be able to take care of your baby, toddler, or child in a way that your healthy friends can, or in a way that you've always envisioned, right? Perfect mother, perfect parent, but that's not going to be the case with chronic. A lot of things will have to be let go. So, and then there are, of course, logistical issues, breastfeeding versus bottle feeding. Sometimes women cannot breastfeed fully. It's a demand on your body. A lot of fluids are lost, blood volume is lost, and you may feel sicker. Conversely, I've had women who did great with breastfeeding, and when they stopped and their period came, that's when they felt sick again. Which birth control methods postpartum are you going to use? It depends on your medical conditions too, because the last thing you want is to have a newborn and then be pregnant right away again. There is a huge factor of sleep deprivation and its effects. There is a higher risk of postpartum depression in women with pre-existing chronic illness, health problems during pregnancy, or if the baby has a medical condition. That's a fact. So you had one baby, it went well, and now you want another one because you feel like you can do it and it's going to be just fine exactly as the other one. But that may not be the case. First of all, every pregnancy is different for everyone, but when you add chronic illness to the mix, it may not pan out exactly like the first baby. So again, discuss it with your partner, your dysautonomia specialist, your OBGYN. Ask yourself, are you well enough to go through another pregnancy and take care of your first child? What is your health status? Anecdotally, some of us in the field agree that the second pregnancy may be more difficult than the first. There are no predictors for the course of second or third pregnancy, even if the first pregnancy went well. No studies. We know it just, all of us have collective experience within our patient population. And if you had postpartum onset of POTS, which is a subcategory of women with POTS, there are no research studies to determine whether subsequent pregnancy would result in symptomatic worsening. We don't know. Again, anecdotally, if some women had a few months, like let's say 6 months of some orthostatic tachycardia, presyncope, baby got bigger, they've been well. Anecdotally, that second pregnancy may put you at a higher risk for more symptoms. So we go to dysautonomia and genes. That's important, obviously, if you decide to have a child. We know that POTS and neurocardiogenic syncope are not genetic disorders in the sense that they do not follow the type of genetic transmission that occurs in cystic fibrosis. Only one form of dysautonomia is genetic, familial dysautonomia, prevalent in Ashkenazi Jews. Parents can undergo prenatal genetic screening. It has been shown in various studies that POTS may run in families. There is a genetic predisposition, 13 to 40%. EDS, as we know, is genetic, most types being autosomal dominant, and there may be a 50% of chance of passing it to your child. But we know there are new mutations. We know there is all kinds of penetrance variability there. Mitochondrial disorders are usually transmitted from mother to children, but may be acquired. And since we don't know what POTS really is it genetic, is it autoimmune, is it mitochondrial, or all of it combined affecting each of the factors may affect another, that also is important to understand mitochondrial disorders, because some patients with POTS do have mitochondrial disorders. Mast cell activation syndrome and autoimmune disorders are not considered genetic like cystic fibrosis at this time, but again, they may run in families with genetic predisposition. So we made it, right, to sexual dysfunction and chronic illness. And what are the effects of chronic illness on sexual health and sexual activity? Many. As I often say, the chronic illness doesn't make you really feel very sexy, right? It's not a sexy thing. So there is reduced sexual desire, impaired sexual arousal, erectile dysfunction in men, lack of lubrication or dryness, lack of subjective pleasure, orgasmic dysfunction, difficulty reaching orgasm, painful intercourse, and sexual aversion. Of course, not in everyone, but those are the common issues that may occur in your patients. And they're not going to bring this up. I try to ask. I am not perfect. I try to ask, but we don't have time because there's like 10,000 issues that we have to go through. Migraines and neck pain and gastroparesis and nausea and weight loss and blood pressure. By the time we get to that, and oftentimes when I know the patient well and when the patient knows me, then we can have hints from like a husband who is not happy or a wife that is not enjoying anything. And of course, I ask men, I often say, I must ask you that, do you have erectile dysfunction? That's my line, for especially for young men. And oftentimes there may be something there that worth discussing. So from the articles and things that I've seen in my patients and what we know is that there are certain tips on healthy sex and chronic illness. And of course, number one is that sex is very important for everyone, even the most disabled patients. So some of the tips are plan sexual activity when you feel less symptomatic. That's intuitive, right? Those times are commonly afternoon and evenings for POTS patients. Avoid certain positions that reduce blood to the brain or cause blood pooling. Make sure the room is cool to avoid overheating. Do not skip medications before sexual activity. And of course, avoid alcohol or caffeine. plan ahead and be well rested before sex. If this is what you're planning on, don't make it like, well, it didn't happen. And it's not going to happen for 6 months and 9 months and a year. But if that's something important, just like your trip, just like your trip to Maryland, you got to plan this ahead, work out the details so that it does happen. Communicate with your partner both your sexual and your medical health needs. We know everybody says sex is good for you. It is. There is a lot of research showing its benefits. It releases good hormones, endorphins, can improve your mood, can even improve your headaches. There is a research on that. Of course, there are types of headaches that can be triggered by sex, so it's, medicine is very complicated, as you know. But it's okay to say no. If you become symptomatic with presyncope during sex, take a break, cool off, drink Gatorade, put the fan on you. Avoid taking hot showers. For Ehlers-Danlos, position is the key. So use support pillows, change positions frequently. Avoid hyperextension of joints. And if intercourse, and we get to this channeling my Dr. Ruth, right now. And so if intercourse is not possible, consider other sensual activities like massage, vibrators, whatever else that doesn't require a lot of energy expenditure on your part. After sex, remain supine, rest, cool off, take your medications if you need it, extra beta blockers, extra midodrine, a salt tablet, a bottle of Gatorade, whatever you have to do. So these are the references that I used for this presentation. Of course, it's a kind of a shorter version. This topic can, be talked about for hours and hours. And most importantly, if you're interested in research, let your physicians know that we need better studies, larger studies, and more numbers, so that we can provide a better information for you. Now, this slide, okay, this is from Jill Brooke. She won 2 awards yesterday. She is very talented. She's my nutritionist. She does nutrition consults for Dysautonomia Clinic. And because we had this year is 10-year anniversary of Dysautonomia Clinic, she and her husband made this wonderful doodle. And so my clinic offers not only neurology and dysautonomia consults. Obviously, I see a lot of Ehlers-Danlos and mast cell activation syndrome patients, but we also offer nutrition consults, psychotherapy. We have a wellness coach. We have a physician who does rehabilitation and physical medicine. She provides exercise recommendations. And we also have a research assistant, a PhD, who helps me with the many studies that I'm doing and want to do. So I'll just leave you with that. If you have any questions, go ahead. I am available.